Yeah, so it gives me great pleasure to introduce the next speaker, Dr. Lim Wei Kang, our senior lecturer in Pediatric Department at University Malaya and newly appointed consultant pediatric neurologist. He completed his pediatric neurology training in and also did a 1-year fellowship training in the Sick Kids Children's Hospital, Toronto, Canada, in pediatric movement disorders and neuromodulation. So it gives me great pleasure for him to give his talk. You can proceed, Dr. Lim.
Yeah, thank you very much, Prof. Fong. Let me just share my slide. So, good morning, everyone. So it's my great pleasure to be having the opportunity to share with you something that I'm very passionate about, which is to manage the pediatric dystonia. They are drug resistant with the DBS. So, let's see. So, yeah, okay. So I have nothing to disclose, but please do not take any photos or video of the slides that I'm showing later, because I have the consent from the parents to be shared with everyone for educational purpose. So let's look at the topic today, dealing with drug-resistant pediatric dystonia in the era of DBS. So when we shall first look at the pediatric dystonia. And as we know, dystonia is a movement disorder. And movement disorders are actually neurologic syndromes in which there is either too much movement, where patient has an excess of movement, or where there's a paucity of voluntary and automatic movements in which patient have too little or no movement at all. And these movement disorder are unrelated to weakness or spasticity. So as I mentioned earlier, movement disorder can be categorized into two broad categories, which are the hyperkinetic movement disorder and also hypokinetic movement disorder. I haven't got enough time to go through each and every one of the movement disorder, but I just want to tell you that in pediatric, most of the movement disorder that we are dealing with are dystonia, as compared to the adult movement disorder, where they see more patients with Parkinsonism. So dystonia is actually not a very new condition, whereby back in 1911, a German neurologist, Dr. Hermann Oppenheim, actually first described this condition after he saw 4 patients with a condition not previously seen by him. So based on the current definition, dystonia is actually a movement disorder which is characterized by sustained or intermittent muscle contraction, which causes abnormal and often repetitive, can be either abnormal movement or posturing, or having both at the same time. And these dystonic movements are typically pattern, twisting, and maybe also tremulous. So they may have also a dystonic tremor. And dystonia is always initiated and worsened by voluntary action. And this means that if the patients are not moving at all, you won't see the patients having a dystonia. And there are many ways we can classify dystonia. We can classify them according to their etiology, which is either inherited versus acquired causes, like HIE and kernicterus. We can also classify dystonia based on the body region involved. For example, generalized dystonia, whereby the whole body is involved, having the dystonia, hemidystonia, or segmental dystonia, whereby 2 or 3 contiguous body parts are involved. We can also see multifocal or also focal dystonia. So based on the phenomenology, which is a description of a movement disorder, we can also classify dystonia by just having an isolated dystonia, or sometimes they can also have a mixed dystonia with another type of movement disorder, for example, myoclonus dystonia or Parkinsonism dystonia. Dystonia can present as a spectrum. So a patient may have just a mild dystonia, whereby they will have a brief and intermittent dystonic movement. And with some triggers, and patient may progress into a state whereby we call them status dystonicus, which is also known more commonly as a dystonic SOM. So status dystonicus is first defined in a case series, which is published in 1998. So in the series, they actually defined status dystonicus as a state of increasingly frequent and severe episodes of generalized dystonia, which necessitate urgent hospital admissions. And this definition is still in use until present. And unlike status epilepticus, which is something that we are more familiar with, there's actually a lack of precise definition at which the worsening of dystonia reaches the threshold of status dystonicus. So there's no consensus on the duration or the number of episodes of dystonia in the definition of status dystonicus. However, in the first paper that describes status dystonicus, they actually emphasize the following life-threatening features of SD, which are bowel weakness, respiratory failure, metabolic derangement, as characterized by a rise in creatine kinase, and also patient may present with exhaustion or pain due to the dystonia. And we know status dystonicus have several complications, including pain, hypothermia, tachycardia, weight loss, rhabdomyolysis, respiratory failure, and also swallowing failure. So I'm just going to show you two videos, and I'm just wondering whether you can differentiate whether this patient are having, they're having dystonia, whether they're having status dystonicus or not. So let's look at the first video. Okay, so as you can see, she actually has a lot of involuntary random movement with some, dystonic movement of involving the face and also the upper limbs, and you can see a lot of posturings. So, and then now I'm going to show you the video on the right-hand side. Okay, and this patient is he's also having a dystonia, but his dystonia is actually quite different from the first video that you saw just now. Whereby he's having a sustained contraction of the muscle, and this is more towards the sort of like a dystonic maybe posturing rather than movement. It's actually quite fixed in a sense. He's actually very stiff in his legs and also limbs. So there are two sort of major types of dystonia. The first one in our first video that you have just seen, which is what we call a mobile or phasic dystonia, where the predominant features are a hyperkinetic movement. And in the second video, the patient having something that we call a fixed or tonic dystonia. And this paper actually published in 2024, which is actually a status dystonical management for pediatric patients. So to help us to manage status dystonicus, we need to actually classify the severity of the status dystonicus into 5 different grades in order to decide which sort of treatment that we need to provide for the patient. So so they're altogether 5 grades. Grade 1 and 2, patients are having dystonia. However, as the patients are lying still, the dystonia will sort of become subtle. From grade 3, 4, and 5 onwards, patients are unable to lie still comfortably, and then they may also have a metabolic decompensation and also life-threatening end organ damage in grade 5, where you need to manage a patient in ICU settings. So this is an acute dystonia pathway, which is actually proposed by the paper that is published in the 2024, the recommendation for management for status dystonicus in children. So when patient meets the criteria from grade 2 to 5 on the dystonia severity scale, we need to then decide whether the patient need to be sent to ICU, whereby if the patient already has a evidence of metabolic derangement, characterized by the CK more than 1,000 and the serum creatinine more than 1.5 times from baseline, and then you need to initiate ICU evaluation. Otherwise, and then you can admit the patient for hospital management. You can, broadly, by giving the patient supportive measures and also pharmacological measures in order to help to reduce the dystonia. So what if, none of this intervention works? I mean, you have given your medications, the patient still continue to have a life-threatening or status dystonicus, and then, you intubate the child, but the patient is still having severe dystonia. So is there anything that we can do after this? So this will lead to the next section of my talk, which is how we deal with a drug-resistant pediatric dystonia. So, but before we move on, let's look at one case that I have a chance to manage after I came back from my fellowship. So this is a 7-year-old girl with a rare genetic mutation, GNAO1 related dystonia. Because of this condition, she started to have intermittent dystonia at the age of 3 years old. As you can see from the video, this is the video shared by her mother. She presented first when she was 3 years old to a private center for having this random and involuntary movement after an episode of febrile illness. And then Moving on, as you can see, she has a lot of hyperkinetic movement and also involving the limbs and also her cheek and also the oral. But this is only just maybe, at the start. After she recover, despite having some dystonic posturing in her feet, as you can see from here, she was still able to stand up and then sort of like, maintain her posture by leaning against to the wall. And this is how she mobilized at home by crawling up the staircases. As you can see, she's having a lot of difficulties to actually mobilize because of the dystonic posturing and also dystonia. But however, her dystonia are getting worse gradually, and up to the point that she is having 5 types of anti-dystonic medication, and also intranasal midazolam for as a rescue medicine when she had very bad dystonia. And due to this high-dose sedating medication, she became very drowsy and sedated after taking the medication. However, there's no way that the doctor can wean off the medication because it's either she's awake and having a lot of severe debilitating dystonia, or if you want to stop the dystonia, she has to be sedated and sleepwalk most of the time. And she became wheelchair bound since the early of 2024 when she was 6 years old due to the severe dystonia. And in October 2024, she had a frequent admission to PICU at Sunway Medical Center, almost 1 to 2 times per month due to status dystonicus. As you can see, this is the video showing her severe dystonia. She's now have a torticollis towards the left side. And then, when dystonia is bad, she's even have a cyanosis due to difficulty in breathing. And I just want to show you the picture of one of her left arm, which is all the scars due to the central line insertion every time she admitted to the ICU for institution of IV medication. So this is the first time when I saw her on the ward just before her deep brain stimulation procedure. This is when she's at the most relaxed state. As you can see, she has like a torticollis to the left side, and then because of the severe dystonia, she already developed contractures in her elbows and also her ankles. So what if none of this work? That means the patient is having a drug-resistant dystonia, and then we should consider deep brain stimulation to try to solve the problem. So this will lead to the next part of my talk, which is about the deep brain stimulation in children. So deep brain stimulation is a neurosurgical procedure, actually that use implanted electrodes, which you can see from here. And this provide electrical stimulation to treat movement disorder associated with Parkinson's disease in adult, essential tremor, and also dystonia. We can also use DBS for drug-resistant epilepsy, and there are also research undergoing to investigate the usefulness of DBS to treat self-injurious behavior in autism. And so far, what we know is that patients have a good response rate to DBS if they have a genetic dystonia such as TOR1A, KMT2B, GNAO1, and also PCAM. So just explain to you quickly how the DBS works. So in a healthy brain, when the cortex actually send off the signal to the basal ganglia, namely the subthalamic nucleus and also striatum, which are the input organs of the basal ganglia, they will actually send further signal to the GPI in order to sort of like fine-tuning the movement that we are going to produce. And the GPI will actually send an inhibitory signal to the thalamus, which then feed back to the cortex. So in patients with dystonia, this pathway becomes disrupted, meaning, where now we have a less control to the movement that we're going to produce. And then as a result, the patient produces a hyperkinetic movement. So by stimulating the GPI, we actually modulating the signal, inhibitory signal sent to the thalamus. So now we can actually have a better control movement that is produced by the cortex. So on February 18 last year, we actually performed the DBS surgery on the youngest patient in Malaysia. So this is Prof. Kalai and his team. He's actually performing the stereotactic DBS implantation on the patient that we saw in the case 1. So this is just a photograph that I took during the operation. As you can see, this is a micro electrode insertion using the stereotactic frame. And then with the guide of a neurophysiological study, we actually can determine how deep the whether the electrode has reached our target site. And then once we reach a target site, and then this, as you can see, this is the leads of the DBS device. And then with the guidance of the micro electrodes, Prof. Kala actually insert these leads into the patient basal ganglia. And this is a post-op CT scan showing that the DBS leads actually in the GPI of the patient. And to assess the severity of the dystonia, we actually use a scale called the Berg-Fun Marston Dystonia Rating Scale. The short form is a BFM-DRS. So for this scale, the highest the number, the more severe the dystonia. As you can see from the slide, for this patient, before the DBS, she actually scored 78 marks out of 120. And after 10 months after the DBS surgery, we actually saw a 70% reduction of the dystonia severity based on this scale. And after the operation, patient has got no more status dystonicus, and there is also an improvement of her weight because dystonia can actually cause a weight loss because of too rapid and also frequent movement of the limbs. So we saw a weight gain, which is something that we want to see after the operation, and we managed to wean off gabapentin and also reduce the chlorohydrate use, and also she doesn't require any more rescue medication for severe dystonia. And this is just a video showing how she is after the operation. As you can see, she's still very scared of me and at the time, and then but you can see the legs are actually more mobile. And this is she was holding to the like a charger to the device because this device requires like battery, and then this battery is rechargeable. Yeah, but as you can see, she's still very cautious of me. Okay, in the interest of time, I will just try to move on to the next one. Okay, so after this case, and then I also had the opportunity to manage another case with severe dystonia. So an 11-year-old girl with PCAN, which is a genetic form of dystonia. So she had, due to this condition, she had neuroregression at the age of 2 years old and started having difficult dystonia from 3 years old onwards. And her dystonia gradually worsened, and she developed very frequent status dystonicus after the age of 6 years old, and up to 7 admissions to either ward or PICU per year due to severe dystonia. And prior to the DBS surgery, she was taking 6 types of anti-dystonic medication, and she slept almost 18 hours per day due to the medication side effect. Okay, yeah. Okay. So I just want to show you that even despite dystonia, she's actually able to understand the instructions. And it's just because of the dystonia, she has difficulty to perform her daily activities. Yeah, as you can see, she was able to follow my command to sort of grab my fingers. Yeah. So she underwent the operation in October last year. So 3 months after the DBS, her dystonia improved almost 60%. There were no more status dystonicus and no regular use of rescue medication. So what actually kind of sort of impact on me is like, the father say finally she can go back, balik kampung for Chinese New Year this year, hopefully after the DBS surgery. Because of her dystonia, father and the family haven't got the time to go back to their hometown for Chinese New Year for the past 8 years. And we move on to another case, 6-year-old girl with, again, GNAO1 associated dystonia. And she has a global developmental delay and also dystonia started when she was 6 months old. And gradually, her dystonia worsened and started having like a 1 to 2 ICU admissions due to severe status dystonicus. And she was also on 5 types of medications due for her dystonia. And on top of dystonia, she also have the epilepsy due to the genetic condition. And however, her seizure control are actually really stable with one type of anti-seizure medication. So this is just to share with you her video. As you can see, this is when she's her baseline. Whenever she moves, there's a lot of hyperkinetic movement of her head, face, and also upper and lower limbs. And this is, when she's on her stroller, relatively sort of comfortable. Whenever she want to move, she will have this involuntary hyperkinetic movement disorder. So imagine, this is, at home, she's moving, and then, this happen all the time. And it's actually quite sad to look at her state because, it can cause pain if, let's say, we let the movement to go on for a long time. So again, we performed the deep brain stimulation in December last year, and this made her the youngest DBS patient in Malaysia. at the age of 6 years old. 2 weeks after the DBS, her dystonia improved by almost like 23%. And oh, sorry, this is when oops, sorry. Okay. The video is not moving. I think that's fine. I just want to actually show you that, after the DBS, she no longer has those hyperkinetic movement all the time. And she's actually appear to be calmer. Okay, I just want to show you a systematic review that look at the cases reported for DBS in pediatric dystonia. And the black bars represent patient with a primary dystonia, and the white bar are the patient with a secondary dystonia due to probably like a HIE, cerebral palsy. As you can see, majority of them, whether they are primary or secondary, they have some improvement. However, in a patient with a primary dystonia, they have a lot more significant improvement as compared to secondary dystonia patient after the DBS. So I have just prepared some frequently asked questions, by some of you that may have the same questions. So how much is the cost of the device? So right now, we are using the device from the Medtronic. This costs 170,000 ringgit Malaysia, but this is rechargeable, and then it can actually last up to 15 years for the battery. So provided the patient are looking after the battery properly. So yeah. And what are the factors, that actually give a good prognosis after the DBS surgery? So papers actually reporting, is a patient having primary dystonia. If the dystonia are the mobile type and there's no structural brain lesion, and patient have a relatively shorter dystonia exposure from the diagnosis. And if they have no contractures, and all these are the good prognostic factors for a favorable DBS motor outcomes. And when should we consider DBS? Obviously, we don't want to consider DBS when the patient is having, a status dystonicus. We will recommend, to do the DBS as early as possible prior to the formation of contractures due to severe dystonia. However, due to the nature of the head development, right now we sort of like, we will perform the DBS operation when patient has already reached 3 years old and older, because prior to that, the skull are still sort of like growing. So maybe that will cause some problem, when we put in the DBS leads. But of course, when I was in Canada, the youngest patient that ever performed DBS over there are actually like 2.5 years. But because the patient was having very bad dystonia, that's why they did the operation actually relatively younger. So just some take-home messages. Dystonia and status dystonicus are more common than we thought and are still quite under-recognized. And I hope this talk will improve our understanding on dystonia and the management of status dystonicus. And I would like to just mention that DBS should be considered in children with pharmacoresistant dystonia and also status dystonicus, because dystonia can be quite debilitating. It can cause a lot of pain and discomfort to the children, and it can happen very, very frequently for children with a severe dystonia. And there's a proverb that say it takes a village to raise a child, but to me, it takes a clinical team to treat drug-resistant dystonia, because this is not a one-man effort. We also need a very good neurosurgeon, anesthetist, radiologist, rehab physician, the rehab, the physiotherapist, occupational therapist, the speech therapist, the pharmacist to help us to manage to manage the medication, and last but not least, the DBS product specialist, because they provide a very good after sales service to the patients. Whenever there's a problem with the device, they will be there to try to do the troubleshooting for them. I just want to share with you some of my experience, and it's kind of stressful to manage children with severe dystonia who are implanted with this expensive device, because there'll be a lot of expectation from the patients and also for their parents after the DBS surgery. And sometimes, I do get emails and also phone calls from the patients' parents to update on their progress, and especially when they are not doing so well. And just before I went for a short vacation early this year, one of my patient parents actually emailed me, to just update me about the dystonia, and then she actually replied me with the sort of like the following photographs. Yeah, so actually she just want to share with me the photograph of a birthday celebration, that she just had in December. So this is the patient that I'm presented as my first case. So as you can see, after the DBS, she has no longer status dystonicus, and then she was able to celebrate her birthday recently. And then you can see she actually smiling happily with her family. So with that, I end my talk, and thank you very much for your attention.
Thanks a lot, Dr. Lim, for that excellent talk. Very touching to see that amazing case series and how much improvement you've made in their lives. So if anyone has any burning questions, you all can put it in the chat box. I just want to ask just one question. You obviously said the best case selection is a primary dystonias, but in terms of the secondary dystonias, of course, we have a big caseload of the secondary dystonias, patients with structural brain lesions, brain injuries in the basal ganglia and those sort of patients. Would those patients also be considered as candidates when they have drug-resistant dystonia? And these are like, your dystonic quadriplegic cerebral palsies and so forth.
Yeah, that's a very good question, Prof. Fong. We can still consider DBS in this group of patients. However, based on the papers published, we know that the response of dystonia to DBS after the operation is not as great as genetic dystonia. People has reported up to 50% of improvement of their dystonia after the operation. The only limiting factor that I will probably mention and also talk to the patient's parents is, before we go for the DBS, if the patient has already got a lot of severe contractures, and also if they have a spasticity, the DBS may not work very well after the operation. That's because, DBS will not be able to address spasticity, and also it won't be able to change the contractures that they have. So they may not be very sort of like mobile, but definitely, I think it will help to reduce the incidence of status dystonicus, if this is the main concern.
Yes. And some parents, of course, worry about, DBS changing their child's personality or development because, there's an implantable neuromodulation device in their brain. What's your take on this? If parents say, will my child still be the same after DBS?
Well, I think because dystonia can come from, can become from a large different groups of etiology. So if let's say the patients are having primary like a monogenic genetic dystonia, if let's say they are intellectually still not so impaired, after the dystonia, gross motor development may improve. That's because they are now less dystonic, so they are able to perform more gross motor and even fine motor function. But in terms of whether this will help them to improve their intellectual improvement or not, I think I'm not very sure, and I think maybe we are also not very sure in terms of as a DBS society. Like a neurologist. I think studies are sort of like looking into the non-motor improvement after the deep brain stimulation in pediatric dystonia. But right now, I think we haven't really got a very sort of like concrete evidence that it will improve the non-motor development. But definitely, there's already a good evidence that it will improve the motor outcome. Yeah.
All right. Very good. And I hope with the advent of new devices in the market, the price of DBS can probably be more affordable to our clientele. With that, I think it's 9:02. I think there's no other questions on the webinar chat. So I'll just like to end this webinar and thank all the participants for participating. Fill up the Google form if you want to get an e-certificate to be sent to your email later. With that, thank you, Dr. Lim.
Okay, thank you.
Okay.